Hello, and it's a really warm welcome to Psychological Professions Week 2024. Great to see so many people joining this call. You're all very welcome. And of course, Psychological Professions Week is this opportunity that we have each year to celebrate the difference, the impact that psychological professions are making for the public. My name is Adrian Whittington. I'm National Clinical Lead for Psychological Professions at NHS England, and I'm going to be working through this session today with a great team of colleagues who are going to be part of the presenting team. So if we go to the next slide, please, I just want to give you a sort of brief intro to the Psychological Professions Week programme as a whole. So if you haven't seen this yet, it's really worth going onto the PPN website, and you'll see a whole range of different sessions running across the week. These are largely being led by our regional PPN colleagues. And we've got great coverage here of a whole range of different topics that might be of interest to you: physical healthcare, widening access to some of our occupations, psychological practice in crisis care, some of our newer roles, particularly the patient and carer race equality framework. There's the Northwest Annual Conference happening this week, trauma-informed care, focus on psychological therapists. So there really is something for everyone here. Please do have a look at the programme and see what else you might want to take part in, be it in your region, or in some cases, the regional sessions are also open more widely. And of course, this is an opportunity to join up with the Psychological Professions Network as well, free membership organisation, free membership network. So please have a look at how to become a member there so that you can keep in touch with all of the developments in this area. Okay, if we go to the next slide, please. What we're going to be focused on today in this session is a more psychological NHS. How can we rise to the challenge of the Darzi review? So, of course, we recognise that right now is quite a challenging time in NHS commissioned services, and the Darzi review brings that into really stark relief. So we're going to be having a look at that today. What does it mean for the psychological professions? What does it mean for a more psychological NHS? And really, we want to hear your views on this. So we're going to be sort of setting the context, but it would be great to hear from you what your thoughts are about what the opportunities are here for us to rise to this challenge. So please do post your comments into the Q&A as we go through. And also, if you have any questions for anyone who's on the presenting panel today, then please post those as well, and we'll pick those up at the end of the session and respond to as many as we can. Great, so we've got a fantastic team joining us today. I'm going to just ask for us to bring the team to the screen now, and people can introduce themselves. Great. Okay, so welcome team. Elsa, over to you first.
Good morning, everybody. My name's Elsa Swarbrick, and I'm the Deputy Director in NHS England for Children and Young People's Mental Health. And I'm also the link between the mental health team and the psychological professions group. So I co-chair the working groups with Adrian.
Thank you. And Paul?
Good morning. My name's Paul Edwards, and I use my lived, living and life experience of mental health to assist and working with national talking therapies teams, Midlands PPN, national PPN, and speak at a number of universities from the patient perspective. Lovely to meet you all.
Thank you. Ali.
Hi everyone, I'm Ali Bryant. I'm a person with complex mental health at the intersectionality of complex and rare physical health conditions, and working alongside the psychological professions is really important for me to speak to their message and speak to the importance of mental health in general.
Thank you. Terry?
Morning everyone, my name is Terry Bryant. I am a carer expert by experience, so I bring that particular perspective into the frame, and I'm involved with PPN as well as a lot of other research activities and also university activities. The underlying theme all the time, making healthcare psychological. Thank you.
Thank you. And Naheem?
Good morning, everybody. I'm Naheem Akhtar, Strategic Lead in the National Mental Health Programme at NHS England, and I work across a number of work streams related to the education and training of psychological professions.
Brilliant. Well, what a great team we have. And I think this really sort of demonstrates that bridge between professionals, policy and the public. So that's what we try and epitomise in everything we do in the Psychological Professions Network. Great. So if we could just go to the next slide, please. I'm just going to give you a brief overview of the session today. Elsa's going to be introducing the Darzi review, what it says, some of the highlights and the lowlights, and then I'm going to be reflecting on where we've got to in this mission to create a more psychological NHS. Where have we got to over the past 5 years or so, and what next in the context of what Darzi says in this review, this important review. And then we're going to be asking Ali, Paul and Terry to reflect on, from a public perspective, having had experience of using services, what does this mean for the public? How can this come together in a way that does create a more psychological NHS? And then a chance for you to, for us to hear from you, your comments on what you think of the direction of travel with all of this, what the opportunities are, and any questions that you might have, we will aim to respond to. Okay, so that's the overview of how we're going to work it today. If we go to the next slide, I'm now just going to hand over to Elsa, who's going to lead us off on an introduction to the Darzi review. Over to you, Elsa.
Thank you, Adrian. So as Adrian said, what I'm going to do in the next 10 to 15 minutes is really just to set the scene and to give you some thoughts about what the Darzi review and what the 10-year plan might mean for the psychological professions. And then we'll really kick off the discussion, first of all, by inviting Ali, Paul and Terry to reflect on, to give us their thoughts and to reflect on what it might mean, and then opening it out for broader discussion. So if we go to the next slide, please. So by way of background, if you remember, the election was on the 4th of July this year. And then within a week, on the 11th of July, the Secretary of State, Wes Streeting, commissioned a full and independent review of the NHS. And he asked for a raw and honest assessment of the issues facing the health service, and looking particularly at access to healthcare, at its quality and also its overall performance. And he invited Professor Lord Darzi to lead that review, who's a surgeon, an independent peer, and also a former health minister. And the intention was that that would feed into the government's 10-year plan to radically reform the nation's health service, and to build a health service fit for the future. So pretty big reform. And the intention was really to be very honest about the challenges facing the health service, so that we could collectively be serious about tackling them. As Darzi later said when he reported, it was essentially a diagnosis. So he said, "I trust Lord Darzi to leave no stone unturned, and I've told him to tell truth to power." And then the review was published 2 months later on the 12th of September. So kind of key points from that are, first of all, that it was very rapid. It was commissioned quickly, and then it was completed very quickly. It was also very thorough, as I said. He was asked to leave no stone unturned. And also there was a real commitment in the report itself to transparency. So as well as the report, there was a technical annex with over 300 analyses which he published for people to see, and you can see links to the review and also the kind of the commission for it on the slide and possibly in the chat as well. So if we move on to the next slide, please. So I'll talk in a minute about the challenges that Lord Darzi set out in his report, but I think it's really important to start with his conclusion, because that's really what we're here to do, is to think about where next, really. So his conclusion was that the NHS is in critical condition, but its vital signs were strong. So deploying his medical language again from diagnosis to now saying that the vital signs are strong. I won't read out all of this quote, but you can see that that he talks in there about clinicians, about NHS staff, about patients, and about but also talks about investment and the need to boost productivity. So, and it's sort of when he talks about patients, he talks about the beating heart of the NHS. So that's partly why it's really important that we're consulting so widely. And he then he sort of sets that this all sets the foundation for reform and the things to build on. I think it's also important to note that he also said in his report that he'd found nothing that drew into questions the principle of a health service that's taxpayer funded, that's free at the point of use, and that's based on need and not on the ability to pay. So that's another important principle that he drew out. So if we can move to the next slide, please. But as I said, he set out some key challenges in the report, and they was broadly grouped into challenges around performance, and then the kind of the drivers for those things. But it's worth saying right at the start, though, before I go through the points on the slide, that he also talked, as well as about the NHS, the Darzi report also talks about the challenges for the health of the nation beyond what the NHS is directly responsible for, and how that's deteriorated and impacted on performance. So, for example, some of the wider influences were things like COVID and the social determinants of health, including housing, income, secure employment. And he also noted the surge in multiple long-term conditions and mental health needs, and particularly for children and young people, and broader public health challenges. So that's some of the wider context to the challenges that you can see, the challenges that you can see set out on the screen. So if we look at performance, first of all, the key areas there were waiting times, including for GPs, for A&E, for hospital treatment, and noting that waiting times had surged for community services and for mental health. He also talked about outcomes for cancer and cardiovascular and dementia care as a challenge in performance. And then the NHS budget, with too great a share being spent in hospitals and too little in the community. So that meant that productivity is low. And I just want to pick up the point actually about productivity here. So I've mentioned it earlier as well, but he was quite clear in his report that falling productivity doesn't mean that the workload for staff is reduced, but he said that rather it crushes staff's enjoyment of work, and instead of putting their time and talents to achieving better outcomes, clinicians' efforts can be kind of wasted on solving process problems, such as things like trying to find available beds. So this is about the efficiency really of services. And then the drivers that he pointed to included, well, first of all, he said that they were heavily interrelated. So they're all interconnected, and they included the impact of the pandemic, the patient voice not being loud enough, sorry, and also that too many staff were disengaged. And then he finally talked about austerity, not in the wider social context that I mentioned earlier, but in terms of the impact that had on funding for the NHS, both in terms of revenue and also in capital funding. There's quite a bit of that in the report. So if we move to the next slide, please. So what does that mean for the psychological professions? We just wanted to pull out a few of the key points that will be relevant to people on this call. So first of all, what the impact of all this is on waiting times, with citing 1 million people waiting for mental health services, and also long waits. He also talked about referrals having gone up as well, so that they've grown rapidly, and up 300% for children from 2016 to 2024. He talks about the workforce and about the challenges in growing parts of the mental health workforce, including nurses. And then there's an issue around parity of esteem here as well. So he pointed out quite prominently in the report that mental health is 20% of the disease burden, but only 10% of the resources available to that. Again, the pandemic came up, so the psychological impact on staff this time of the pandemic still being felt, with significant increases in referrals, so adding to the pressure. He noted the growth of autism assessment referrals, with 125,000 people waiting over 13 weeks. And then he also noted some success stories, including talking therapies and the psychological component to cardiac rehabilitation. So if you go through the report, and I really do suggest that you do, you'll see there's quite a lot of references both to mental health, but also to the wider psychological profile, I suppose, within the NHS, and to the work that the psychological professions may need to be involved in. If we can go to the next slide, please. So having done that very broad diagnosis, he then identified some themes that he suggested would may be able to help to repair the NHS. He wasn't asked to give policy recommendations in his report, but he did recommend note these themes, suggesting that they should be considered alongside strategies to improve health more generally, so health as well as healthcare, and also reforms to social care. So again, placing this within a wider context, and I mean, very much picking up on the challenges that were noted earlier. Those themes were re-engaging staff, re-empowering patients, very, very prominent. Locking in a shift of care closer to home. And we'll see this is picked up in one of the 3 shifts that many of you will have heard him talk about. Improving productivity, which I've touched on already. Simplifying and innovating care for a neighbourhood NHS, a sort of more closer to home NHS. The role of technology being absolutely critical. There was a theme around clarifying roles and accountabilities in NHS structures. And then finally, the role that the NHS can play in contributing to the nation's prosperity in terms of its productivity, but also in terms of the economic activity and themes like that. So as a sort of very big organisation within the UK. So if we move on to the next slide, please. So that those themes sort of boil very much down into 3 big shifts in healthcare, which are underpinning the 10-year plan, which I'm sure many of you will have heard of. So first of all, a shift from sickness to prevention. Secondly, a shift from hospital to community, a really strong focus on care close to home, essentially. And then finally, a shift from analog to digital. And I mean, you will know that there are already very good examples, particularly within the field of mental health, of where those shifts have already been carried out. So the shift towards prevention, the MHST programme, mental health support teams in schools in particular, has been really growing a focus on secondary prevention within a school setting, so where children and young people spend most of their time in an environment that they're comfortable with. So so trying to address needs early before they escalate, even if they're quite serious needs. And then in terms of hospital to the community, well, there's been a real growth in community mental health services and other services, as you know, including currently piloting some 24/7 open access neighbourhood health services. And then the shift from analog to digital. Again, I mentioned talking therapies earlier, and there's been some great progress around that in terms of booking appointments, for example, to underpin that shift. So what I'm saying is there's a good platform to build on, but these are the 3 areas that we'll really want to focus on. So if we go to the next slide. So where all that takes us to is to a new 10-year plan for the NHS. As I said at the start, the intention of the Darzi review was to inform a 10-year plan. And what that provided was an analysis, the diagnosis, if you like, of where Lord Darzi and the people that he consulted found that the NHS is now. But the next step is really to develop a plan for the future. So as I mentioned, this is very much about reform. And the first thing, and one of the reasons that we're having this session, is about engagement. So really understanding the voice of patients, the voice of the public, and the voice of staff. So the Change NHS programme, which was launched in October, is very much the biggest staff engagement exercise in the NHS's history, harnessing frontline views and also harnessing the views of patients and the public. So that includes everybody with an interest in psychological healthcare. We really want to be able to draw your views out today of what Darzi and what the 10-year plan might mean for the psychological professions, whether that's in mental health or whether that's beyond that. And also an aim to make the best practice normal across the country. So you can see the link where suggestions and proposals can be submitted. So that's everything I was going to say. If I can hand back to you now, Adrian, please.
Thanks very much, Elsa. That's fantastic overview, really very, very helpful. Just to remind people, do comment in the chat. So please do post your thoughts and reflections on what Elsa had to say and what I'm about to say into the Q&A. Or if you've got any questions for Elsa, do post them there as well, and we'll seek to pick those up at the end of the session. Great, so I'm going to be moving on now to reflect on progress towards a more psychological NHS over the last period of sort of 5 years of policy. And then so a few thoughts about what next and how we might engage around what Darzi has had to say. So if we can go to the next slide, please. So 5 or so years ago, we set out to look at, could we create a more sort of joined up vision for the psychological professions? And so back, it was 2020, we actually started this process. We sought to try and answer the question, how could the psychological professions have the maximum impact for the public? And we didn't want to come up with a dusty policy document on this that was created by 3 people sitting in a room somewhere. We really wanted to ask the public, and we wanted to ask psychological professionals. So that's what we did. And we ended up with thousands of responses from professionals of many different disciplines, from members of the public, from all across England and in fact beyond, seeking to answer this question. And based on what came in, we undertook a thematic analysis and came up with a shared commitment that from those responses, it was clear that the psychological professions as a whole were keen to make. And that commitment was to transform lives and communities by extending and embedding psychological knowledge and practice across the whole of health and care. That's a bit of a mouthful. I sometimes summarize that as creating a more psychological NHS. Obviously, that isn't the whole of it, but that's a headline that I sometimes use to sort of encompass that direction of travel. Within this vision, though, there were other commitments that were very clear from the responses that we received. And we've grouped those into 5 areas, 5 planets, as they're represented here, that were generated through this process that was called Psychological Professions into Action. And these commitments fell into the areas of make all health and care psychological, help our communities to thrive, put people first, transform and innovate, and unite and increase diversity in the psychological professions. And I think this has been a sort of very significant process in terms of bringing the psychological professions together, with a more joined up voice that aligns to the needs of the public and what we're hearing from the public, and allows us to move forward in a shared direction, which, to be frank, was difficult until we started this process of trying to join up a bit more across the psychological professions. There were many different voices, not always speaking in harmony. People may remember my herding cats slides that I've used on previous occasions. And I think that led to real difficulty in being heard, particularly in sort of policy circles. So creating a more shared sense of direction has been very important, and the vision has been an important part of that. And this remains live. You can find a lot of further detail on this on the PPN website, including the commitments that we drew from that thematic analysis in each of these planet areas, the more detailed commitments. But I'm going to now reflect on where we've got to based around these some of these sort of planet commitment areas, because I think that gives us a good framework for just thinking about where we've got to in 2024. So if we go to the next slide, I'm going to start with unite and increase diversity in the psychological professions. And I'm starting with the unite part. Okay. And so this is about bringing the psychological professions together. Obviously, the vision itself and that process of arriving at it was part of this, a significant process and intervention, if you like, in itself. But also, over the past few years, we have got a lot clearer about who the psychological professions are. And I think that wasn't always apparent. It wasn't something we could always speak about in a way that we had kind of agreement and alignment on. So we now have a grouping of psychological professions that we recognise as part of the sort of professional leadership structure of psychological professions, which falls into three broad categories. Psychologists, which includes practitioner psychologists, it also includes assistant and associate psychology roles. Second category is psychological therapists, and then the third grouping is psychological practitioners. And so these three broad categories, and you'll see here 21 occupations listed under each of these, make up the psychological professions. Of these 21, 17 have uniquely psychological professions, professional leadership within the NHS architecture. But we also welcome art, drama and music therapists and medical psychotherapists who have professional leadership elsewhere, but who exist in the overlap. And so we want to have the sort of best benefits of both worlds. And of course, the purpose of doing this was to unite rather than to exclude. So I want to recognise there are many other groups that make a really important contribution to psychological healthcare, who may not be named specifically on this list, but who do make a really, really valuable and important contribution. But overall, bringing the groups together and understanding them this way, I think has been quite helpful in creating that join up and uniting. So next slide brings us on then to a second strand of uniting, and this has been about the development of the psychological professions networks. So since 2021, I think it is, we've had a psychological professions network in every region of England. And these are membership networks that are free to join. They're commissioned by NHS England, and their purpose is to inform, enable and influence NHS commissioned healthcare to maximise the benefits of the psychological professions for the public. Incredibly, there's now over 17,000 members of the PPNs around the country, which is fantastic. And this is a photo taken when we last met as a group who are sort of leading and supporting the development of the PPNs. This was in Liverpool, not in Ukraine, as you may think, and brought together sort of chairs, program managers, assistants, experts by experience involved in the PPN development. These networks started over 10 years ago now, in 2013 in the Northwest, under Geeta Bhutani's leadership, and Geeta and I worked together to seek to support the establishment of PPNs in the other regions over the last few years. So it's full credit to Geeta for all of that fantastic work. So we now have these networks in every region, and that's part of what you'll see across this week is the sort of benefits of those regionally led approaches, bringing people together, seeking to connect psychological professionals, policy and the public. So this has been another key uniting factor. Next slide, please. So what next in uniting the psychological professions? Well, there's a couple of things in the pipeline that I just wanted to raise your awareness of. The first is that we're in the closing stages of establishing guidance on recognised registers for the psychological professions for use of title in NHS commissioned healthcare in England. And some of you may have seen in the media recently coverage of quite a growing voice calling for statutory regulation of psychotherapists. This hasn't been something that the government has wanted to consider over the past few years. And so what we've set out to do in that interim is create at least greater clarity for the public and for services about what register someone should be on to practice under a particular title in the NHS. We think that's really important, and that will be forthcoming, we think, in the new year. Another potential development is to build on the success of the PPNs and to extend the scope of our sort of regional infrastructure to a broader remit that we might call schools of psychological professions. This is all subject to further funding, etc. Isn't certain yet. But if this does come to pass, this would mean continuing with the sort of network function that the PPNs hold, but also extending that to a broader sort of regional workforce remit that would cover implementing workforce development programs around the psychological professions and leading on the oversight and enhancement of education quality around all of our psychological professions education programs, similar to how NHS England has schools for other professional groups such as pharmacy and medicine. Okay, next slide, please. Right, so I'm going to focus in now on the planet that is make all health and care psychological and where we've got to with this. And what you'll see on the slide here, so this is about how we've progressed this agenda by expanding the psychological professions. It's obviously a big part of making that all health and care psychological is extending and expanding the psychological profession. It's not the whole of it. Obviously, we also want more psychological practice delivered across a whole range of occupational groups. But in expanding the sort of specialist psychological professions groups, you'll see we've come really a long way. So if we look back 8 years, back to 2016, you'll see that we've here grown by 100%. So we've doubled in size as a professional grouping over that period. In the past 5 years, we've grown by 65%. And we now have whole-time equivalents in post of over 32,000 psychological professionals. So this is a very significant impact, I think, for the public. Next slide. And this growth reflects all of our occupational groups, all 21 that were in that list that you saw earlier. And this is from our most recent benchmarking, NHS benchmarking survey that was published late last year, that shows that we have 3 really big groups: clinical psychologists, psychological wellbeing practitioners, and CBT therapists. We also have a number of other groups with over 1,000 whole-time equivalents, including assistant psychologists, counsellors, psychological therapists of other types beyond CBT. And then we have a number of other groups, some of them quite sizable, others growing rapidly. So this rich kaleidoscope of different roles, all making a unique and important contribution. Next slide. So how have we got here in this expansion? Well, it's largely down to growth in our education programs. So this slide shows how this is our best estimate of numbers of people trained in a psychological professions occupation. So this isn't sort of upskilling people who are already in one of those occupations, it's developing people into a new occupation in the psychological professions. And you'll see that the training numbers here have grown really significantly over the past few years, seem to have sort of stabilized and steady leveled out over the last year, but really significant growth over the period. And at the same time, if we go to the next slide, we'll see the other factor that's been really important in this expansion, which is that for us in the psychological professions, NHS retention seems to be holding up pretty well. This is contrary to what people often sort of report anecdotally, but this is what the data is showing us, is that when you look at the percentage of psychological professionals who are leaving the NHS under 55, the orange line, so that pre any kind of retirement cutoff, over 55, which is the blue line, and then reducing their hours to work more part-time, which is the grey line. When you look at all of these different methods by which people might reduce their hours in the NHS, it's pretty static, really, for the last 9 years. This is obviously as a percentage of the whole workforce. The only exception to this was actually during the sort of lockdown period when people stayed put more. As you might expect, it was difficult to sort of move to a different type of work, or people didn't want to take that risk, or perhaps, you know, we couldn't move overseas, those sorts of things. So there was a reduction in departures during that period, but otherwise very static. Of course, we are twice as big now. There's twice as many psychological professionals, So to remain static like this as a percentage, twice as many people are leaving. Let's be clear about that. But it's as a proportion of the whole, it seems to have remained exactly the same over the period. So perhaps some of the sort of experiences, the anecdotes that are very sort of important about, there appears to be a problem with people moving on from the NHS, perhaps is down to the absolute numbers rather than the percentage of the whole. Okay, next slide, please. So what next for expanding? Well, in June 23, we had the publication of the first ever psychological professions the first ever NHS long-term workforce plan. And this is a really important publication. We were pretty pleased with where the psychological professions landed in it, because this plan set out for the NHS as a whole to model the requirements for workforce over the next 13 years. And for the psychological professions, what that showed us in the modelling was a growth requirement for another 24 to 26,000 posts by 2037. So if you recall, we're currently at about 32,000. I think a year ago we were maybe at about 30,000. This is an almost further doubling that's signalled here in the next 13 years. Importantly, though, the plan also contained the commitment to review and potentially increase the ambition, and that's work that's currently going on now to just look at, is this model, does this still stand up given sort of some of the additional demand requirements, both based on the increasing sort of prevalence and referrals to services, but also based on commitments that are already in place, such as the further expansion of NHS talking therapies. So we're doing further modelling on that at the moment. But the plan as it stands contains a commitment to expand all of our main groups, psychologists, psychological therapists, and psychological practitioners across pathways. So not just mental health, but mental health and physical health. The education supply model in it covers just some of our groups at the moment, but there is a commitment to train, in addition to psychologists, to train 15,000 more psychological therapists and psychological practitioners over the period to 2026, and then we'll need to sort of look at the modelling to build on that from there. The plan also contains really important commitment to growing apprenticeships further, and a strong emphasis on retention. These will be important to us. We obviously have apprenticeships for psychological wellbeing practitioners, clinical associates in psychology, and emergent apprenticeships for family and systemic psychotherapy, and the beginnings of a development for cognitive behavioural psychotherapy. So these are going to be important elements. Next slide, please. Okay, so the next area I want to focus on where we've got to is the increased diversity part of this commitment, unite and increase diversity in the psychological professions. And I suppose where I want to start is to say that not all of our professions or all of our parts of the services are the same in this regard. So here we have the workforce composition of NHS talking therapies clinicians in 2023, when this was surveyed through our benchmarking survey, and this shows the ethnic mix of that workforce group compared to the ethnic mix of the England working age population. It's a pretty close match, and it has been, in fact, since the very early days of NHS talking therapies. So I think this is a matter of pride. There's obviously not any cause to sort of rest on laurels here. We need to continue to ensure that these services are inclusive of all, supportive of staff across all backgrounds, and reaching out to make sure they're optimally accessible and producing equivalent outcomes across all of our protected characteristics for those who use the service. But from a workforce perspective, there's a close match here between the workforce and the population in terms of ethnicity. But we do have more significant issues that we needed to attend to in part of our occupational group. So if we go to the next slide, one of the areas where we knew we needed to take targeted action, if we look back to 2019, was in clinical psychology, where there's a really strong and clear consensus that there were some issues that needed to be attended to here, particularly around ethnicity and inclusion and equity of inclusion in these in the clinical psychology occupation. So with leaders in the field of clinical psychology, the professional leadership across professional bodies, the leaders of the education programs, we set out, and those who were themselves seeking to get onto these programs, we created a 9-point action plan collectively that we then built into the recommissioning of clinical psychology training a couple of years ago. So it's a requirement that people follow this. And what this commits, collectively commits the education programs to do is to make sure that there's leadership commitment to this agenda of increasing equity of access and inclusion across different ethnicities, that there's staff and supervisor training to support it. We have mentoring programs for potential ethnic minority applicants to the training to seek to iron out differential disadvantage if you don't have family contacts or others who are already in the profession. We've implemented paid experience schemes, commissioned those so that underrepresented groups who can't afford to do what it sometimes takes, which is to work voluntarily, can have paid experience opportunities to that will help support their applications. The courses have undertaken curriculum and admissions reviews, many of them looking at contextual admissions of different forms. And the courses have also explored and implemented support for minoritised trainees on the programmes. So through this programme of change, I think you'll see in the next slide that there's been something of an important forward movement. And so I just think it's important to note this. If you look at this is a busy slide, but if you look at the 2 bars on the left here, you'll see the qualified applied psychologist workforce group as a whole in the NHS. In 2019 is the left-hand bar, and then the next one is 2024. And this is split down in the bars by ethnicity, the keys at the bottom of the slide. So what you'll see here is we're starting from a place, if you compare this to the England working age population 2021, which is the 3rd bar, starting from a place with this workforce that really wasn't representative by all ethnic minorities, and we're still not there. But there is a sort of small but important shift starting to become apparent, with a greater showing of ethnic minority workforce within this group over time. But we're not where we need to be, because this representation is not matching on to the England working age population, which is the sort of minimum we would expect to see. And this gives us a very clear signal that under the Equality Act and our public sector equalities duty, we need to go further. We need to continue pushing this agenda. You'll see that the problem here isn't that UK undergraduate psychology courses don't have the ethnic mix that we would expect, because the next bar, the 4th bar, shows that mix, and that's pretty close to the mix in the England working age population. So the pool that we're drawing from into clinical psychology training is, mixed in the proportions we would expect for our population as a whole. So the good news, I think, is that we are seeing really significant change in the entry to clinical psychology over time. And the next 5 bars show that. So from 2019 through to 2023, which is the last data that we have, you'll see there's a really significant change underway. And by 2023, in fact, that intake showing a very close match between the ethnic mix of the intake and the undergraduate psychology ethnic mix and the England working age population mix. So we need to continue with this, because that's the only way we'll start to see more appropriate representation of ethnic minorities across the whole of this workforce as the cohorts work through over time. Obviously, this will take time, but I think this is important to see that we're going in a positive direction. Representation, of course, isn't everything. It's only part of a picture about inclusion, and inclusion means a lot more. It means the programs being safe spaces for people to work and learn regardless of background, and so we need to keep the focus absolutely on that at the same time. Next slide, please. So where next in terms of increasing diversity? We need to do further work. So we need further targeted action to tackle inequalities and inequities in admissions, particularly around this clinical psychology group, but also recognizing that we need to look at the other occupations and continue to do that too. So we need to focus on across all protected characteristics and in fact socioeconomic background. If you look at the sort of data that we have from Clearinghouse for clinical psychology, you'll see that those applying from postcodes who have the lowest participation rates in higher education also have the lowest application success rates. So there is an issue with socioeconomic background that we need to explore and further work on. Also, of some concern is that over the time that we've expanded clinical psychology training, doubled in size over the past 3 or 4 years, this has opened up more of a gap in success rates in application between women and men, with men now significantly underperforming in their applications compared to women. So we need to understand that and make sure that recruitment and selection processes are absolutely equitable and welcoming of all based on potential and ability. And further consolidation of the work across equity and inclusion across ethnicities. You know, that I'm not suggesting a change of focus here, but a broadening of focus. That we need to absolutely keep our attention on all of these different characteristics. Okay, great. Next slide, please. My final area that I want to reflect on is the commitment that we made through the vision to transform and innovate. And where have we got to with this? Well, there's an important element of this that was about building better leadership infrastructure for the psychological professions. And where we've got to with that is, I think, a really much stronger recognition of the role of Chief Psychological Professions Officer. These are the most senior psychological professionals leading professionally within each provider organisation. We've brought that group together, tried to connect them more into the world of policy, and greater recognition of that role. This, of course, isn't the only role that's important in leadership. So there's a great need to focus also on the sort of levels of professional leadership beneath this role. But that's where we've brought people together. We need that broader focus too. As I said earlier, we've established a PPN in every region, which is fantastic. That sort of regional professional leadership infrastructure. Please do get involved with your regional PPN if you're not already. And we have national professional leadership in place now in the form of my role and the teams that support it. Next slide, please. There's, of course, a lot further to go in terms of transforming and innovating. And I think the Darzi review presents us with some real significant sort of opportunities and signals the challenges that we need to apply ourselves to in transforming and innovating. One of the areas where I think we can do more is to be clear about all of the different areas of psychological practice that our groups work across. And these are summarised here helpfully by colleagues who wrote this up actually in the Clinical Psychology Forum in April. Do have a look at this for more information. But broadly speaking, what this signals is that there's work for the psychological professions across a whole range of different areas of practice. Creating psychologically informed environments. I think this speaks to the sickness to prevention shift a bit. So it's enabling environments as a whole to be more psychologically informed. Psychologically informed interventions. So these aren't therapies, but they're very important ways of supporting people with best evidence-based practice, perhaps briefer or more focused or targeted psychological interventions. Many of our new roles are particularly focused in this area of practice. And then we have specific model-based psychological therapy. So these are the sorts of therapies that have a particular sort of governance infrastructure around them, are perhaps NICE recommended. They might target specific conditions, very important part of what we do, and obviously significantly deployed in some of our pathways, particularly. So NHS talking therapies being one of these, which makes up 40% of our overall psychological professions workforce, or thereabouts. And then the green area here, bespoke psychological practice, being that sort of formulation-based, drawing on evidence and theory from a psychological perspective to create unique programs of change or intervention in areas perhaps where there may not be a specific model-based psychological therapy that is recommended, or where there are unique circumstances that mean adaptations are needed. And I think if we can increasingly think about all of these areas of practice, it helps us in our conversations to move our transformation forward. Because sometimes what I find is that when we're focused in one of these quadrants, it can feel like we're forgetting about all the others. And I think if we collectively hold all of these in mind at the same time, it can really help us to move forward with all of them. Okay, so just briefly now on the Darzi review, if we move to the next slide. Returning to Elsa's summary of the 3 big shifts that Darzi signals: sickness to prevention, hospital to community, analog to digital. I don't think it's for me or for us on the panel necessarily to determine what each of these might mean for psychological professions practice, but I do want to just, I suppose, offer a reflection on this, but we really want to hear from you in the audience as to what your views are and thoughts on this as well. So if we go to the next slide, I think that there's some opportunities here for us to drive this change towards a more psychological NHS using these shifts. And this probably needs to be a big part of our thinking over the next sort of policy cycle, the next 5 years. So think about illness to prevention. This really connects with that planet in our vision that said, you won't be able to read it there, it says help our communities to thrive. And it's a set of commitments that people were really keen for us to make as psychological professionals back when we created the vision. But I think it's probably fair to say this has been a hard one to implement. Money tends to follow treating illness rather than prevention. But Elsa has signalled some of the ways in which we have been able to really make a difference here through the mental health support teams, for example, creating a more preventative approach in schools. So one of the things we probably need to be focused on over the next period is demonstrating the impact of psychological practice in prevention, so that we can really support the building of a preventative approach using a psychological way of working. The next shift from hospital to community, part of which is about this more neighbourhood focused approach. I think this does give a really important opportunity for psychological professions to continue that work around making all health and care psychological, with a strong role in these new neighbourhood-based health services. So we need to make sure that those neighbourhood-based services really do integrate a multi-professional approach, a biopsychosocial approach to mental health. Mental health is signalled as being an important part of that shift, but it needs to be that biopsychosocial. Let's not forget the psychological part. And finally, analog to digital, there's great opportunities here. And I think so many of the opportunities are about how systems work more efficiently and can help release time for clinicians to do clinical work. That will be really important. At the same time, there's a component of this which is obviously about implementing digitally enabled ways of working, such as digitally enabled therapies. It's going to be really important, isn't it? And this links to our transform and innovate set of commitments in our vision, that where we make these transformations and change, that they are linked to evidence. And there are some risks here, I think. There's a risk in rushing to sort of everyone download an app that can, you know, help you with your psychological well-being, that we don't attend to what works sufficiently. And so I think psychological professionals have a particular role in attending to what works and making sure that where we undergo this shift towards more digital forms of healthcare, they are evidence-based. Okay, next slide. Thank you. But all of this, whatever direction this goes, needs to be aligned to the needs of the public And I feel really positive about how Darzi recognises that, the need for public engagement to drive change. And of course, this links to our most important commitment in our vision, which is put people first. And so that's why it's a real pleasure to have experts by experience speaking as part of this panel, talking about how might this align to the needs of the public from their individual perspectives. But of course, if you're a member of the public, we're all members of the public, please do comment on this yourself in the chat today. So on that note, I'm going to hand over now to Elsa, who's going to introduce the next part of the session. Thank you.
Thank you very much, Adrian. That's a fantastic overview, both of the progress that's been made in the psychological professions, but also the opportunities that we have ahead of us. We're going to have wider discussion quite soon, and I can see there's been lots of questions coming in on the chat. But before we do that, as Adrian said, we wanted to bring in our experts by experience, Ali, Paul and Terry, for their initial reflections on generally what they've heard today, but also more broadly. And the kind of the question really is if we're talking about a more psychological NHS, how do we get there through the three shifts that we've been talking about, from sickness to prevention, from hospital to community, and from analog to digital? And I know that you've got lots of thoughts about that. So if I can bring in Ali first, that will be great.
Thanks very much, Elsa, and thanks to you, Adrian, as well. I think, kind of considering that from my lived experience perspective, why is that shift from hospitals to community so important? And the Darzi review gives us, kind of, as Elsa and Adrian have demonstrated, that wealth of statistics and suggestions on why this is necessary. But for all of us, from our first to our last breath, the NHS is there at the point of need, but things do need to shift. In considering what the next 10-year NHS health plan for, delivery in spring 25 has to say, as a person living with complex mental health and physical health needs at the intersectionality of multiple long-term conditions, that shift, and the suggestions concerning hospital and community really speak to me and to the broader challenges in the system. We're all aware of waiting lists. We're all aware of, kind of what the benefits of bringing care back to the heart of communities means. For the public satisfaction, we know Lord Darzi shares in the review, public satisfaction is at its lowest ever. So, acknowledging that challenges such as underfunding have, really impacted waiting lists, waiting times, GP appointments and workforce growth, it's really now time to drive forward community-based care. And as I've said, Elsa and Adrian have spoken to this, but for me as a patient, it's just reading that review, it's so hard to comprehend. There were 345,000 referrals where people were waiting for more than a year for first contact with mental health services, the equivalent of the city of Leicester. For me, that's heartbreaking. And it's an illustration of where the mental health, kind of 20% of disease burden is not supported because it only received 10% of resources. That's where we need to make change. I know the decline in my physical health and my mental health that corresponds with waiting list times. And, my quality of life, my productivity and hope. I am a statistic. But I'm also a person, and somewhere I'm on a list, still waiting. But I'm waiting now, having read the Darzi review, in the hope that earlier access within the community will take that pressure off of hospitals as care becomes available in the community. The report illustrates that the share of the budget is weighted not to the community or to mental health, but to hospitals. And, within those major themes that Lord Darzi identifies, hardwiring those kind of flows of funding to the community and to mental health so that services can to adapt and innovate. And I know that Paul and Terry will speak to more of this with the themes that they are speaking on. But we must consider that, for example, I can share a lived experience example. It's Lord Darzi shares that 7% fewer daily patient and outpatient appointments are held by each consultant. Now, this is one of many backlogs, and I reflected on this, kind of around that particular statistic. I worry for weeks before I have a consultant's appointment. My mental health is adversely impacted. I travel a long way across the city to a busy waiting room and eventually see the consultant. I require no physical examination. It's the routine. How are you? Any changes? And I return to a crowded waiting room to wait again for blood tests, with my anxiety elevated, knowing that the letter will arrive in weeks time, weeks away, in which my mental health declines. But if my tests were completed and conducted in the community a couple of weeks before an appointment, that data would not just inform the consultant about my appointment, but it would also mean that with no physical examination required, that potentially that innovation would mean that my appointment could be online, freeing up the flow to people who are on the waiting list, who need that first appointment, who've been waiting for such a long time. And so really kind of thinking about it from that personal perspective really makes me see where innovation and change are absolutely necessary. I think also the patient public voice, with me being here today with Paul and Terry, Change NHS is a game changer. I think that patient and public voice, I think that sharing and innovation from members of the public who've been there and done that will really affect change going forward. And, I can only congratulate the fact that this is actually available. And I was probably one of the first people to actually engage with it and fill it in and complete it. So in my own words, poorer quality of life, particularly around social determinants of health and multiple long-term conditions and mental health, will be better managed with funded community-centred care, with new roles, workforce growth and training, so everyone in general practice, mental health and community services can be that lifeline in healthcare to simplify and innovate care delivery for a neighbourhood NHS and for the 10-year plan to make our NHS stronger in the future for everyone.
Thank you, Ali, and sorry about that, my microphone was off. It's so important to hear how the lived experience of the current situation. And what also struck me from what you were saying is how intertwined these three shifts are, aren't they? So actually you started talking about hospital to community, but you also talked about prevention, you also talked about analog to digital. So can I bring in can I bring in Paul or Terry for their reflections either on that or on the other themes?
Yeah, I think that what Ali said. Thanks, Terry. What Ali said is so true, and it comes into what I was going to talk about. But I think what we've got to look at is the demographic of the country, both in areas and population, and see how we can reach those. And the best ways that we can reach those is listening to the patients. So whether it be a rural area or whether it be a city area, let's use non-NHS places. Let's look at in a rural area, let's look at maybe having buses that can go out to those areas, but with people who can not only give blood tests but also give psychological advice. And I think that the one thing from the Darzi report that struck me is one of the first things he said is, despite all the challenges and low morale, the NHS staff are profoundly passionate and motivated to raise the quality of care for patients, and the talents must be harnessed to make positive change. And I think that what we need to do is look at that ground level and say, look, you're doing it on a daily basis at the ground level. What are your ideas? And enhance that and listen to, as managers, to that. And I think that comes with, from sickness treatment to prevention. And somebody who's been very passionate about bringing together physical health and mental health. I don't understand why in every oncology department in the country we haven't got a psychological practitioner to, when somebody is given the worst news in the world, they aren't given that psychological arm around them before they leave with some kind of prevention. But what we do is we wait for them to enter depression or anxiety, and then we put them on a waiting list. To me, that's not satisfactory. And I think that, you know, with the parity of esteem we want between physical and mental health, the one-stop shop is going to be the way forward, whether that be in the community, whether that would be in the hospitals or whatever. But I think that, you know, for me, it's about going from purely a reactive response to include a proactive prevention. And I understand there are serious mental health conditions. We're going to have some reactive, but we also need some proactive. And what we want is the exciting times that Darzi is going to give us is for clinicians and patients to embrace how we're going to move forward. But let's do this together. And I think that we're in a really excited place. And if we look at the psychological components of the cardiac rehabilitation that Darzi talks about, and also about the diabetes and the preventative side of that, you know, it's out there. Let's listen to him. But, you know, one of the most frightening things for me reading the Darzi report was in the fact that ICBs aren't always sure of exactly what they should do together. And this is where we need to bring that coordination both down from a national level, but also up from the local level, from local to regional to national. It's a three-way communication. It's not a diktat for any one of those. So I think that, you know, for me, it's like, let's get passionate. Let's add to people on the ground level, including the patients, and we've got a really rich way of moving forward.
Brilliant. Thank you, Paul. And I love the let's be proactive, not reactive. I mean, in a sense, that feels like it's the heart of prevention, doesn't it? And then also just pulling out that this is across all areas of care. It's not just mental health. There's the contribution that the psychological professions can make everywhere. And I mean, and as we've been hearing a lot today, this is about the three. I think you talked about the three-way engagement, really, didn't you? So at every level. I'm going to turn to Terry next. I want to make sure that you have an opportunity to contribute as well. So over to you, Terry, and then we'll open it up for wider discussion with those people who dialed into the webinar.
Thank you. I mean, just a quick reflection on the previous two speakers. I think what they do together is show very clearly the need that all three of these areas, all three of these shifts inform one another, interact and work together to achieve a common end. But I'm going to speak very quickly about analog to digital, which is a challenging area. I mean, what does digital mean? Many people don't really understand it. I'm certainly put my hand up as one that doesn't understand the nuances of digital and AI, but what will it mean on the ground? What will it mean to people like myself? I mean, bottom line, digital is offering an effective and an accurate way to record and communicate information between patients. It's offering a way of moving forward, of building on something that we have the basis for and can do, but we're not actually doing it as yet. So what does digital actually mean? What do the technologies mean? To some people, it's panacea, nirvana. It will solve everything. To other people, they're slightly apprehensive or scared about it. They're not familiar with digital technology and AI technology. But what it will offer is this way of pulling things together. So what does it mean in real terms? Telemedicine. Sensors, wearables, sensors that people can wear to feed back to the clinicians. Smartphones, smartphone apps, smartphones being platforms for social media, giving that information back, which will also be really, really useful for research to analyze and come up with new possibilities and new directions to take travel in. Electronic health records opening up to become also patient health records. So the patients can not only be aware of what's there, but can contribute and build on that. And also areas like natural language processing, which the technology is there to take the words, spoken words, written words, and transform it into a digital format that can be used for researchers and also for those people that deliver healthcare. In isolation, digital technology won't work. One little bit here or there will have a very limited effect, but together the effect is multiplied exponentially. So it needs to be implemented at scale, and it's not good enough just to give people, service users, carers, to give them agency. you also have to give them the means to exercise that. So that's one of the challenges down the line. So what are we looking at? A data-rich healthcare environment, but it requires greater digital literacy across the board, not just the clinicians, not just the healthcare professional, but also by the public. That's something else we're facing. Pathways and services will be reimagined, but patients have to remain at the centre, and the patient benefit has to be the target and the driving force behind any of these changes. There are hazards here. It mustn't threaten the precious interhuman bond between service user and clinician. It's not replacing psychologists and supporting staff, but augmenting their healthcare and making it better for the patient. So as aspects of care shift towards and closer to the patient, as both Paul and Alison have referred to, this will empower patients to manage their own health. But that as a one-liner is not enough. They need to be helped to understand that and how they can work together to improve their health. So, and technology must also, there's a risk that it will promote or exacerbate inequalities. That needs to be, an awareness of that needs to be built in right from the very beginning, and caution and how we move forward on that. And with that always on the radar of people. And ultimately, digital technology with the reporting of data back will offer the possibility of the uniqueness of every individual to be recognised, and it will lead to better and more tailored healthcare. So technology will also fill evidence gaps. And Adrian touched upon this. Developments and movements forward need to be evidence-based. And at the moment, the time it takes to do the research, generate that evidence, analyse it, can be quite convoluted. And digital technologies offer the possibility of that process being rapidly speeded up. So answers can come back more quickly. What works, what doesn't work, hard decisions have to be made. If this isn't working now, okay, let's move, let's try something else. So we need to be responsive to that. But digital technologies ultimately offer the possibilities of amending and improving and informing the care that is provided, and also the potential, looking at mental health, to actually a new understanding of what mental health means, how the determinants are, particularly around these social determinants affecting mental health. So yes, it is a time of opportunity. It is also a time where we can pin down, try to be as firm as we can on the direction that we wish to take.
Thank you so much, Terry. I mean, it's a very small sentence, isn't it? Analog to digital, and what you've really helped to do is to unpack what that means and to cover things like sort of from digital literacy, which I think means about partly just understanding what the opportunities are and what the scope is of digital. I really like the point about the fact that this doesn't mean non-human, this doesn't mean non-personal. It's about enabling personalised care and about supporting relational care, and then of course the contribution that digital can make to evidence, which of course is then about improvement as well. So really helpful. Thank you so much, all of you, for your comments. We've got a couple of minutes. Does anybody want to have one last word? I think pull straight off on the buzzer there.
Can I just say that I think that, you know, I put it in the Q&A, but I think what we need to do is we need to look at CYP. We need to look at how we can enhance the fact that these young people need hope, because it's one of those things that, you know, we can enhance all of this, but I think we need to look at, and all of it is going to go to that analog to digital, sickness to prevention. We need to give these young people hope. We don't want someone who's 56 years of age like me taking part in a campaign and say I'm still struggling on a waiting list, because that doesn't give them any hope. We need to look at how we can do that. And I think from hospital to community, we need to be looking at universities, we needed to be looking at schools, we needed to enhance it. You know, we are going to have a lot of new psychologically trained therapists. You know, let's enhance this. You know, I'm always hearing students saying, well, I can't get people with anxiety and depression to treat. Well, let's set up hubs then in universities. Let's set up hubs in schools. Let's assist these people before they have problems, when they start struggling, and let's educate them in a really caring way in their own communities, in a very safe space.
Thank you very much indeed. And I think that's a great note to end on. Ali started off by talking about this potentially being a game changer. And we've talked through some of the opportunities, some of the kind of the granular detail, if you like, of the headlines. But then I think to end on a note of hope, I think is really important. So with that, thank you very, very much for bringing to life and some of the opportunities and also experiences that you've had. And I'm going to now turn to Naheem, who I think is going to chair the next part of the session.
Thank you, Elsa. So everyone, again, I'm Naheem Akhtar, Strategic Lead in the National Mental Health Team at NHS England. So first of all, we want to say thank you for everyone joining this morning. It's been really interesting, and I hope you found it informative. And thank you to everyone who's been posting in the chat in terms of your feedback and some of the questions you've got. Just picking out a couple of themes regarding the feedback. There was positivity from Anna Mariotos around the recognised registered, and thanking the team on the work they're doing around protecting the roles. So that was received well. There was a lot of interest around the psychological professions workforce data that you shared, Adrian, and we've still got questions coming in. Before I go into the questions, I'm just going to ask everyone, when you have an opportunity, we're going to put a link in the chat so you can share your feedback on this session. That would be really valuable and help us improve it for the next time round. So colleagues and participants who are watching can do that. That would be appreciated by the team who've kind of put a lot of work and effort into this, and obviously for the colleagues on the panel as well. Again, this morning we're not going to have enough time as we anticipated to go through the questions, because we want to observe the 2-minute silence at 11 o'clock for Armistice Day. So hopefully everyone agrees with that. But we'll go through some of the questions that have come in. So the first one, and probably the one that's the most popular, is around, I think it was sent by Catherine Davies, regarding the inequality in resources in CYP. So the question is, there are 24% of the population but account for 11% of NHS expenditure, with the longer WT than adults in acute and mental health services. How can we influence this, especially with the paradigm of moving from sickness to prevention? CYP services are prevention key in the long term. So I think this is what Paul was just kind of touching on, but not in the detail. So Elsa, is that okay if I put this one to you?
Yeah. So clearly CYP mental health is an area very close to my heart. But I think you're right that investing in children's mental health and investing in children generally reaps really long-term benefits. Sometimes it's hard to be able to see those benefits immediately, because it takes they roll out over such a long period, which can sometimes be hard to make the investment case. But I think as the evidence builds, it's a very important case to make, and I think the opportunity of a 10-year plan is critical. So if we think that today's 8-year-old will be 18 years old in 10 years' time, and that as a result of the changes that you are contributing to or that you're advocating for, that might make a material difference to that person's own life, and to their kind of health and happiness and their long-term health outcomes, but also, of course, to the economy and to society in general. So absolutely critical case. In terms of framing this within Change NHS, I'm just very struck by, and I would encourage people to contribute on this issue, to really raise the voice for children. I think we all know that this is important, but sometimes there's obviously there's often a focus on what's urgent, what's kind of what's coming up now for people. So I think this is an opportunity both to raise the issue of children and young people, as Darzi did, in fact, both for physical health and for mental health. Set out what the benefits are. So what's the evidence that we have for those benefits? Where is there either data that you know of? Where is there evaluation evidence? Where is the research? We've just been seeing lots of information coming through from the latest Sure Start evaluation, for example, where we're really beginning to see what long-term effects can be of early intervention. contribute about where you think investment can be best placed, and where you think it would reap the most rewards. I think we know that funding is tight, so it's really important to be well evidenced and clear about where the impact will really happen, while bearing in mind inequalities, which is another issue actually that Darzi raised. And then finally, one of the themes, if you like, within the Darzi review, and I think this is why there's been such a sort of a public conversation about this, is that we know that there's lots of work to build on. We know that there's lots of good practice out there. We know that lots of good things are being done. So this is an opportunity to try and share that, really, and to try and make sure that the playing field rises for everybody. So if you know of good practice, if you know of things that are working well, particularly around the areas of performance that Darzi pointed to, please do contribute that in your feedback to the plan and to Change NHS.
Thank you, Elsa. That's really helpful. Okay, if we move on to the next question. So we've got a question from anonymous user. So Adrian, I'm going to put this one to you. How do we encourage counselling psychologists into the NHS when the majority have to self-fund and find their own placements? They are a diverse bunch and often go on into the profession as a second career.
Thank you very much for posting that question, and I want to recognise that all of our psychological professions make a really important contribution, and all form a really significant part of our workforce, however big or small they are. The NHS benchmarking survey in 2023 showed there are about 325 counselling psychologists in NHS commissioned healthcare. This may be an underestimate because we know that there's a lot of miscoding in the electronic staff record, people not necessarily coded as a counselling psychologist. So this is a small but significant group. The question is about how could we encourage people in. There's no reason why an employer can't seek to or make open opportunities for employment for counselling psychologists, including as trainees. In fact, there's some really encouraging work in some local areas on this already. I think the important thing here is that we don't make assumptions about needing to recruit psychological professionals according to specific qualifications, and unless there are good competency reasons to do so. So where there's a job that would be appropriately filled by a counselling psychologist, let's make it very clear that it's open to counselling psychologists and make it a competency-based recruitment process to enable that. Yes, it is an unequitable situation at the moment. Not all psychological professions trainings are funded. Some are funded, some aren't, largely for historical reasons. But there are potentially ways in which we could do more for bringing in more of our fantastic counselling psychologists into NHS practice by funding training opportunities, using vacancy. We have a high level of vacancies in some areas for psychological professionals, and so we could use some of those vacancies to bring in funded training opportunities, funded qualified opportunities, and I think this does require focused attention. So thanks for raising the point.
Cheers, Adrian. Thank you very much. So we've got another question from Vicky Ayers. Given the mental health, psychological needs of the staff and the closure of staff support hubs, the lack of parity and the message this sends to staff, what commitment and reassurance will be provided to staff that the psychological needs will be supported, allowing staff to remain at work and performing effectively? So I don't know, Adrian and Elsa, do you want to take that between yourselves?
Shall I start off, Elsa? I don't mind. I mean, what I would say about this is, yes, the hubs have made a really important impact where those have been deployed, and in some areas have been possible to continue with even after the sort of central funding ended. And so it's a huge congratulations to all psychological professionals who have often been involved in leading those. I do think, though, the approach to staff wellbeing obviously needs to go well beyond the provision of staff wellbeing hubs, and so needs to include, the broader attention to cultural factors in services that make jobs sustainable, enjoyable, rewarding for people, so that they want to stay in them and can do so and stay well. So we do have a sort of broader program around something called the People Promise that makes a commitment to a whole range of different sort of areas of culture to support people's well-being at work in the NHS. Compassionate leadership is part of this. So I think all of those elements need attention, and I think psychological professionals actually can play a really important part in that and have particular skills to bring to make those sort of programs and that attention meaningful. Don't know if you want to add, Elsa.
I mean, I agree with you, Adrian, about that. I think it's important to frame this as part of the wider workforce and about how important the wider workforce is. And I think we've seen that throughout both the Darzi review and also the Change NHS programme. In terms of the specific point here, I mean, I would again, I think it's if you're going to respond to the Change NHS sort of conversation, I think it's really important to make the case to show how sort of how the hubs have benefited, where they've had most effect, and also to think about how you can make the case for how this benefits the workforce and the wider workforce, and including the things that Adrian's talked about, and also the ultimate impact on patients, on performance, and on delivery, which is absolutely critical. So please do contribute sort of in the wider sense, but also on that specific issue.
Thank you both for the response. And the final question / feedback we're going to come to is around the focus on shifting from sickness to prevention and the hospital to community is positive, and in terms of the scope there is to kind of make this happen and the roles that can support this to be embedded within the community. So I'm going to ask Paul, Terry and Ali for your kind of views on this, because you did touch on this on your feedback. So yeah.
I think it's so important, isn't it? And you know, listening to that patient perspective is going to be key. And one of the things that I know Ali and Terry and all us other experts by experience within the PPN network are keen to do is to get this voice forward. And something we've been working on in the Midlands specifically is a scoping exercise to see what experts by experience are used by trusts and ICBs and educational providers, and bring all those together in some form of community of practice if possible, so we can get the wider voice out from a lot of different diverse areas into various different kinds of psychology practice, both in hospital, both in education, and bring out that best practice and that knowledge. So having it less siloed, so we're not all asking the same questions and answering them all ourselves and getting different answers. You know, if the answers are already out there, let's embed that and let's get it. And I think that's really important with all areas of work we do. We become less siloed and we learn from each other and take that information far quicker.
Yeah. Thank you, Paul. So I'm going to close this session there. As I mentioned, we want to finish a bit earlier, so I'll hand over to Adrian.
Thank you very much. I want to say three things. I want to say thank you to our panel. You've all been fantastic, great presentations, great contributions, lots of food for thought there. I want to draw the audience's attention to this edition of Clinical Psychology Forum. It happens to be in a clinical psychology publication, but it's relevant to all psychological professionals. It covers a lot of the workforce sort of content that we've talked about in this session and more. It's free to download. Please have a look. And finally, if we go to the next slide, just a reminder, we've talked a lot about this consultation, Change NHS. I would love it if everyone with an interest in psychological healthcare responded to this, be you a practitioner, be you a member of the public. So please do. And finally, just to say thank you very, very much. We'll end there. It's been great to kick off the week, and I hope you enjoy the rest of it. Thank you very, very much.